right, welcome to the deep dive. Today we're getting into an injury that, well, you might not hear about every day, but it can be a real game changer if you're active. We're talking about pectoralis major tendon tears.
Yeah, the pec major, that big chest muscle.
Exactly. And if you're someone who pushes yourself, maybe in the gym, understanding this one is pretty important, thinking about, what could potentially happen.
Absolutely. It may be not as common as, say, a rotator cuff tear, but a pec major tear.
Yeah.
That can seriously impact your strength, your daily function, not to mention sports.
So our mission today is really to break it down for you.
Right. What is it? How does it usually happen? How would you know if you had one? And crucially, what are the options to fix it? We're basing this on, medical studies out there.
Okay, let's jump right in. What exactly is a pectoralis major tendon tear? What's happening?
So, in simple terms, it's when that strong tendon connecting your main chest muscle, the pectoralis major, literally pulls off the bone.
Pulls right off.
Yeah, an avulsion. That's the medical term, a forceful detachment. It's thankfully pretty rare, but definitely a significant injury when it occurs.
Rare, but like you said, significant. Who tends to get this injury? Is there a typical person?
There is, actually. It's rare overall, less than one case per 100,000 people a year, something like that.
Wow, that is rare.
It is. But what's interesting is reports have been going up since about 1990.
Yeah.
And it overwhelmingly hits men, usually younger guys, say 20 to 40 years old.
Okay.
And very often it's weightlifters. The bench press is, well, it's the classic activity associated with this injury.
Yeah.
The forces involved are just immense.
Bench press, yeah, I can picture that heavy weight coming down. Where exactly does it tend to tear? Like what part gives way?
The most common place is right where the tendon attaches to the upper arm bone, the humerus. Specifically, it's usually the tendon from the lower, larger part of the muscle. We call that the sternocostal head that avulses, pulls away from the bone.
Got it.
And it's also worth mentioning, unfortunately, that anabolic steroid use is known to be a risk factor. It can weaken the tendon.
Okay. So let's talk about that moment of injury. During something like a bench press, what's actually going wrong mechanically?
It typically happens under what's called an eccentric load. That means the muscle is contracting strongly, trying to resist a force, but it's also being lengthened at the same time.
Like lowering the weight slowly.
Exactly. Think about that downward phase of the bench press. Your pec is working hard to control the weight, but it's stretching out. The tear often happens right near the bottom of that movement,
Okay.
particularly in sort of the last 30 degrees as the bar gets close to your chest. That's when the strain is highest on certain parts of the tendon.
So the muscle's fighting the weight down, gets overstretched, and pop.
Pop is often what people report feeling, yeah. And it seems there's a sequence to it usually. The lower fibers of that big sternocostal part tend to fail first.
Right.
Then the upper fibers of that same part. And if the force is high enough, the clavicular head, the part attached to the collarbone, can go too.
Why those lower fibers first?
It's biomechanics. In that specific bench press position, arms wide, bar low, those inferior sternal fibers are stretched the most. They're just at their limit.
That makes sense. It paints a clear picture. Let's maybe zoom out a bit and talk about the muscle itself, the pectoralis major. What's its structure?
Sure. So imagine this big fan-shaped muscle covering your upper chest. It actually has two main parts, or heads.
Two parts. Okay.
Yeah, there's the clavicular head, the upper part, which starts on your collarbone, the clavicle, and the top of your sternum. And then there's the larger lower part, the sternocostal head.
Sternocostal, that's the bigger one.
Much bigger. Yeah, it makes up over 80% of the muscle mass. It attaches all along your sternum, the breastbone, down to the cartilage of ribs 1 through 6, and even connects a bit to the fascia covering your abs. It's a broad origin.
Okay, two parts starting wide. Where do they come together? Where do they attach to the arm?
They both merge to form a common tendon. And this tendon inserts onto your upper arm bone, the humerus. It attaches just on the outer edge of a groove where your biceps tendon runs.
So they join up near the shoulder.
Exactly. And there's a neat anatomical detail. As the fibers from the two heads come together to form the tendon, they actually twist about 90 degrees.
They twist.
Yeah, so the fibers that started higher up on your chest actually end up attaching a bit lower on the arm bone. And the lower fibers attach higher up, like twisting a rope.
Huh. Interesting. So what are the main jobs of this muscle then? What actions does it power?
Its main functions are bringing your arm across your body, that's called adduction, and turning your arm inward, which is internal rotation. Think hugging or throwing a ball.
Okay.
The upper clavicular part also helps lift your arm forward, that's forward flexion. So yeah, it's involved in a lot of powerful upper body movements.
And how is it controlled? What nerves make it work?
It gets signals from two main nerves branching off the brachial plexus in your shoulder area. The lateral pectoral nerve mostly handles the clavicular head and upper sternal part,
Okay.
and the medial pectoral nerve takes care of the lower sternal part. And just for context, the pec major is one of four muscles connecting your arm to your chest. There's also the pec minor underneath it, the subclavius, and the serratus anterior around the side. They all work together.
Right, a whole system. Okay, we've got a good handle on the what and how. Now let's switch to the patient perspective. If someone tears this tendon, what would they actually notice? What are the telltale signs?
Well, usually you'll remember the exact moment it happened. People often describe feeling or even hearing a sudden pop or a distinct tearing
A
sensation.
pop, yeah, you mentioned that.
Right. It often happens during a resisted movement, like pushing something heavy or bringing the arm forcefully across the chest or rotating it inward. And immediately after, you'd expect pain, usually quite significant, and weakness in the shoulder and chest area.
Okay, sudden pop, pain, weakness. What would a doctor look for during an examination? What visible clues might there be?
There are several classic signs. You'd likely see swelling and bruising, which can be quite extensive, spreading across the chest and down the upper arm.
Bruising down the arm.
Yeah, and sometimes if the bruising tracks further down the arm, it might suggest the tear is closer to where the tendon attaches to the humerus, right at the end.
Interesting. What else?
Another thing is the drop nipple sign. Because the muscle retracts, pulls back when it tears, the nipple on the injured side might look lower than the uninjured side.
Ah, okay.
You might also be able to feel a gap, like a defect, where the muscle should be. And the nice curve you normally have at the front of your armpit, the anterior axillary fold, can look flattened or sort of disappear. This becomes more obvious if you ask the person to push their hands together in front of them.
Right, trying to activate the muscle shows the defect.
Exactly. And then there's the weakness. You'll find significant weakness when testing their ability to adduct, bring the arm across the body, and internally rotate it. Forward flexion might be a bit weak too, but usually less so.
So it's a combination of the story, the symptoms, and what the doctor finds on exam. How do you confirm it for sure? What about imaging?
Good question. Standard x-rays are often done first, mainly to rule out other things, like a fracture. They don't usually show the tendon tear itself.
So x-rays are mostly negative.
Mostly, yeah. Sometimes, if a little piece of bone got pulled off with a tendon that's a bony avulsion, you might see that fragment on the x-ray. But really, the gold standard for diagnosing these is an MRI scan.
MRI makes sense for soft tissues.
Definitely. MRI is excellent at showing the tendon, differentiating between a partial tear and a complete rupture. It can pinpoint the location, is off the bone at the muscle-tendon junction or within the muscle belly.
Does it require a special kind of MRI?
Often, yes. A dedicated MRI protocol focusing on the pectoralis region is usually best. A standard shoulder MRI might not capture the insertion point clearly enough.
Okay.
The MRI shows the severity, how far the tendon is retracted, if it's pulled away completely. One small caveat is that sometimes, if only the larger sternocostal part is torn, but the clavicular part is okay, the partial tear can be a bit masked or harder to appreciate fully.
Right, the intact part might hide it a bit. Okay, so the MRI gives a clear diagnosis. Once you know someone has a pec major tear, what happens next? What are the treatment paths?
Broadly, there are two main paths: non-operative treatment, so no surgery, and operative treatment, which means surgery.
Let's start with non-operative. What does that involve?
Non-operative usually means putting your arm in a sling for a period, focusing on rest, using ice to manage swelling, taking pain medication, and then eventually starting physical therapy to regain motion and strength.
Who is that approach generally best for?
It's typically considered for maybe older, less active individuals, or for very minor tears, perhaps tears within the muscle belly itself rather than the tendon, or low-grade partial tendon tears.
But what about for younger, active people? Say, that weightlifter we talked about.
Yeah, for younger, active patients who want to get back to a high level of function, non-operative treatment often leads to, well, less satisfactory results.
So,
They often end up with a lasting cosmetic deformity, a visible asymmetry in the chest because the muscle stays retracted. More importantly, they usually have significant permanent strength loss, especially in adduction, bringing the arm across.
that sounds limiting.
It is. Recovery can also be delayed. Patient satisfaction tends to be lower, and getting back to sports or heavy lifting at the previous level can be really difficult, if not impossible.
Okay, that makes a strong case for considering surgery in those individuals. When is surgery the preferred option?
Surgery is generally recommended for most acute tears, meaning fresh injuries in athletes and younger, active people. especially if it's a complete tear, or the tear right where the muscle joins the tendon. The goal is to repair it, to reattach the tendon back where it belongs.
And what are the outcomes like with surgery?
Generally, much better for that active group. Surgery tends to provide reliable strength recovery. People have a good chance of returning to their sports and activities, and overall patient satisfaction is usually higher compared to non-op treatment.
Does it matter exactly where the tear was?
Good surgical results can often be achieved regardless of the tear location, whether it's off the bone, at the musculotendinous junction, or even sometimes within the muscle belly if it's a significant tear.
What if someone has an older tear? Maybe they didn't get it treated right away. Is surgery still an option?
Yes, absolutely. For chronic tears, ones that are weeks or months old, surgical reconstruction is often still a very viable option.
Reconstruction, meaning not just a direct repair.
Right. If the tendon has retracted too much and can't be pulled back to its original spot, or if the tissue quality isn't great, the surgeon might need to use a graft like a donor tendon to bridge the gap.
How do those reconstructions do?
Outcomes are generally good. Maybe not quite as consistently excellent as an early primary repair, but still significantly better than doing nothing for an active person with a chronic tear and ongoing weakness or functional problems. Sometimes, even after several months, a direct repair might still be possible if the tendon hasn't retracted too far.
Okay, so early repair is ideal, but later options exist. You mentioned different surgical techniques earlier. Can you give us a quick rundown?
Sure, so whether it's non-op or pre-op, the initial phase is similar: sling, rest, ice, pain control. If surgery is planned, early gentle passive motion is often encouraged once comfort allows.
And the surgery itself.
For a standard open repair, the surgeon usually makes an incision along the line between your deltoid and pec muscles, the deltopectoral approach. Then the main goal is anchoring that torn tendon back to the humerus bone.
How do they anchor it?
There are a few common ways. They might drill small tunnels through the bone and pass strong sutures through them to secure the tendon. Or they might use suture anchors, which are like small screws or plugs that go into the bone and have sutures attached. Another method uses buttons placed on the far side of the bone for fixation.
Is one method better than others?
Studies comparing them generally show similar excellent results overall. There's maybe some subtle biomechanical evidence suggesting that the bone trough or button techniques might be slightly stronger initially than anchors alone, but clinically, they all seem to work very well.
And if the tear is in the muscle itself?
If it's a tear within the muscle belly or right where the muscle turns into tendon, sometimes a direct repair, just stitching the torn muscle edges together, can be done.
Okay. And for those reconstructions of older tears, what grafts are used?
Right, for reconstruction, the first step is often releasing scar tissue to mobilize the retracted muscle. Then, to bridge that gap, an Achilles tendon allograft, a donor tendon, is a common choice. It's strong, readily available, and avoids taking a graft from the patient's own body.
An allograft, so from a tissue bank.
Exactly.
Hmm.
Another option sometimes used is a hamstring tendon, either allograft or autograft, meaning taken from the patient's own hamstrings, which is then woven or folded to create a strong graft. These grafts are then secured to the humerus, often using those bone tunnel techniques.
Okay, that covers the main approaches. Now, like any procedure, there must be potential downsides or complications. What should people be aware of?
Yes, that's important. Re-tear is probably the most significant surgical complication, though thankfully not super common, maybe around 5 to 7% of cases.
Mm-hmm.
It often happens where the sutures attached to the tendon itself. That can be the weak point.
Okay, re-tear is one possibility. What else?
Persistent pain after surgery can sometimes be an issue for some individuals. It's probably the most common longer-term complaint. There's also a chance of some residual weakness or a cosmetic difference compared to the other side, even after a successful repair.
And the usual surgical risks.
Right, like with any surgery, there are small risks of infection, nerve injury, or blood clots, but those are generally quite low for this type of procedure.
All right, this has been incredibly informative. Let's try to distill the main points for someone listening. What are the key takeaways?
I think the main things are: 1, this is a specific injury, often tied to high-force activities like bench pressing. 2, recognize the signs that sudden pop or tear, followed by pain, weakness, and bruising in the chest and arm.
Right, be aware of those symptoms.
3, while non-operative care exists, for active people wanting full function back, surgery is usually the recommended route for acute tears, offering better strength and return to activity.
And different surgical techniques work well.
Exactly. And 4th, even if it's an older injury, don't assume nothing can be done. Reconstruction is often a good option for chronic tears with persistent problems.
So the core message for listeners seems to be, if you suspect this injury, especially after a specific event, get it checked out promptly.
Definitely. Prompt diagnosis is key. It allows for a proper discussion about your specific situation, your goals, and the best treatment plan to get you back to doing what you want to do. Don't just try to push through it.
This has been a really valuable deep dive. It highlights just how powerful that pec muscle is and how crucial it is for so many movements we take for granted.
It really does. It's a reminder of the incredible forces our bodies handle, but also their limits. Understanding how these injuries happen helps appreciate that balance.
Thanks so much for breaking this down for us and for everyone listening.